All right, I'll just give it one more minute as people start to join in before I kick us off. For those who are just joining in, we have a little quick poll to just survey, get some information about how much sleep you got last night. Okay, we'll go ahead and get started. So hi, everyone. I'm Devin. I am the VP of Partnerships here at Gennev. I'm so thrilled that we're able to spend this time together having a conversation around all things menopause. This is your space to learn, to ask questions, and to connect yourself to your menopause journey. A couple of housekeeping items. We will be recording this session and we'll send you the recording, so no need to take notes. And we'll save time at the end for Q&A, but feel free to drop your questions in the chat at any time. So in this session, we plan to discuss menopause, pull back the layers, and learn together. There's so much on this topic right now, and we at Gennev are so here for it. So in this session, you can expect to understand menopause, what changes happen, the time frame, and the symptoms. You can expect to learn different ways of managing and handling menopause symptoms, getting out in front of it and turning it into the powerful change making experience we know it can be as women, and discuss ways that you can support someone close to you or yourself through the menopause journey. Many of us start menopause and it hits us like a Mack truck, and we feel unprepared and we often feel alone. So through the years, much of the menopause conversation has been wrought with misinformation and misinformed medical advice. Gennev's here to change that. So I'm excited to introduce Dr. Rebecca Dunsmore-Sue, the Chief Medical Officer here at Gennev. Dr. Dunsmore-Sue is one of the top experts in menopause care in the United States, and she built the Gennev Clinic from the ground up. Dr. Dunsmore-Sue continues to conduct clinical research for women's health while leading the Gennev Clinic. She also happens to be a TikTok star who shares great information on the menopause experience. So I highly recommend you follow the Gennev TikTok account for all the great information that she provides. So in this session, we'll talk through what menopause is, the symptoms you can expect, how Gennev treats those symptoms, our MD model of care, and next steps. So I'll go ahead and turn it over to Dr. Rebecca Dunsmore-Sue.
Hi, everybody. I'm really happy to be here. And thank you, Devin, for the lovely intro and the TikTok shout out. This is the new phase of my career, I must admit. Had to get my 20-year-old to show me how to follow myself on TikTok. So always learning in menopause. So we like to start by centering around understanding what the menopausal transition is, because I think there's a lot of just lack of understanding about how this all happens. And so, a lot of us have heard that menopause is defined by 12 months without a period. And that is true. That's how we formally define it. But that doesn't always apply to every woman. Some women don't have a uterus or their uterus doesn't bleed for various reasons. So it's harder to determine where we are in that transition. In my mind, I think about menopause as 12 months without a ovulatory cycle. So basically, when you go through menopause, your ovaries have stopped producing eggs for fertility. And when they stop producing eggs, they also stop producing the hormones that get those eggs out. And those hormones are the ones we know so well, estrogen and progesterone. And so once that's happened for 12 months, we consider you fully menopausal. However, there's a whole bunch of time before that date marker where you may be symptomatic, and whether you're fully menopausal or you're perimenopausal, which we'll address a little bit in the next slide, the symptoms can start long before you meet that marker. I also talk a lot with women who don't really know where they are in that transition. And so we often use different questions and different symptoms to try to determine that if we don't have the marker of a period to tell us. One of the biggest questions we get is, well, why don't you just do a blood test and tell me where I am in that transition? And the answer is because they don't tell me where you are in that transition. When you're in the perimenopause or leading up to menopause, those blood tests are different every single month and different weeks of the month. And so all the blood test tells me is what you're doing at that particular point in time. It doesn't tell me what's going to happen the next month or 3 months down the line. And once you're fully menopausal, I can pretty much predict the blood tests, so they don't give me any added information over what I already know. I'm going to see if I can move slides. I can. So exciting. So what symptoms do women tell us about in menopause? And the answer is there are so many symptoms. We have data that it can be up to 34, 50, depends on who you ask, different symptoms that have been attributed to menopause. The ones we have listed here are the most common ones that we talk about and that we see women complaining of. And I bet you thought, hot flashes would be number one on this list. While about 70% of women will experience hot flashes in some form, whether they be daytime or those nighttime hot flashes that cause sweating.
I'm listening to a meeting.
Can everybody please mute themselves? Sorry. Well, the hot flashes are the most common symptom. They're not the most distressing symptom for most women. So women expect them. For some women, they can be very distressing. For others, they're just an annoyance. The symptoms that actually distress or cause the most quality of life impact for women during the perimenopause and the menopause are weight changes and body image changes. So our weight not only changes, but it shifts towards the middle. We have mood changes in perimenopause are a little bit different than from menopause, but we can see mood swings, depression, and anxiety. We see insomnia and sleeplessness, and this is a huge impact, especially on women who are very productive in their daytime jobs or their lives. Like not getting that good night's rest can be really, really devastating. And then we also see changes in our sex drive or our libido. And those can be confusing and frustrating because oftentimes we're getting to the point where our kids might actually be leaving the house and we think it's going to get better. And in fact, we have so many other things going on that it can be really difficult. Um, so all of these symptoms can be normal. Every woman will experience a different subset of these symptoms, but all of them are things that we deal with on a regular basis and are happy to talk about and or help you manage in your life so you can live the best life through the menopause transition. So I sort of mentioned this in the first line. There are different phases of the menopausal transition. The menopause is that day or moment, 12 months without a period. Usually in the US, the average age is about 51 and a half where that happens. But leading up to menopause is this big period of time we call perimenopause, which just means around menopause, not very specific terminology there. But perimenopause can last for women anywhere between 2 and 10 years leading into that last period. We often see women get a lot of symptoms of perimenopause before they see any discernible change in their periods. So when a woman starts to head into menopause and perimenopause, what's going on behind the scenes are that you're still releasing eggs. So you're still having the hormonal changes that get eggs out every month or 2 or 3. But those eggs that you're releasing aren't as high of quality as they used to be. So it takes more driving from your brain to your ovary and more hormone from the ovary to get those eggs out. What that causes on the back end is that you may not see a difference in the cycle of your period, but what you may see is a heavier flow because so much more estrogen went into the getting of the egg out. You might see, because you go so high with estrogen and then drop off so low at the time of the period, a lot more mood shifts, especially around the period. So I've heard it called PMS on steroids. This, what I like to term a roller coaster of hormone, can have a lot of impact in terms of symptoms even before you see the periods change. The periods change in a couple of different ways. So the classic description of perimenopause is that the cycle of the period gets a little bit closer first. So you go from maybe a 27-day cycle to a 25-day cycle, and then it starts to skip or miss a period or two here or there. But I've had women come in and have normal periods up until their last one and then never have one again. And I've seen women who have, every 2-month periods for 4 years. Everybody's a little bit different in how that happens through this transition. But the symptoms are what sort of carry over for everyone. And then post-menopause. Postmenopause is just every time after that that 12-month mark. The reason we bring it up here is because postmenopause is when our physiology changes and we really need to start thinking about our long-term health. And I would argue we actually need to start thinking about our long-term health in perimenopause to set us up for the best possible postmenopause, especially when it comes to things like bone health, cardiovascular health. These are the most important health risks for women as they age and go through menopause, and making sure that you're doing everything you possibly can to preserve those is really critical. So why do we exist? Gennev exists. So I am an OBGYN, board certified, have worked in this space for many years in a traditional practice, and realized in that setting, especially because I live in the Pacific Northwest, where here in our, hub of Seattle, we have lots of great providers, but all around us, women had no access to care. And so they were going to physicians who want to do their best with this, but really have received no training in this. So as an OBGYN, I'm sad to report that approximately 20% of OBGYNs receive any formal training in menopause during their residency, which is crazy to me because menopause is half of a woman's life and we're women's health specialists. The numbers are equal or even lower in primary care fields. And it's not their fault. They want to do the best for you, but they just don't have the knowledge and the resources and the training to do it. So our goal at Gennev was to provide this service nationally, to be able to say, hey, we've got this panel of menopause expert physicians who can see you wherever you are and meet you where you are to treat your menopause and talk to you about all the health risks and benefits of that treatment. So let me explain sort of what somebody who comes to Gennev does. So this is a, example patient. We'll call her Allison. She's in that perimenopause to menopause transition. She's struggling most with her weight gains, her hot flashes, and her anxiety. And so she comes to the Gennev platform and makes a telehealth appointment. And on that telehealth appointment, she gets 30 minutes to sit with a physician. She'll have filled out all her health history ahead of time so the physician can review it. So that 30 minutes is really spent in conversation, exploring her symptoms, exploring her particular concerns or particular needs. At the end of that appointment, if appropriate, she will receive medication, whether that be hormonal medication or other medications. As part of that appointment, we also always do a mental health screening because the importance of mental health through the perimenopause and menopausal transition can't be overstated. She will, because weight gain is one of her concerns, and we spoke about it, and she's doing a lot of the right things, but could use some guidance. She's set up with a series of appointments with our registered dietitian nutritionist team. So we have a phenomenal team of women's health and menopause expert registered dietitian nutritionists. And yes, they work on diet, but they also are behavior change coaches. So they work a lot on how do we incorporate movement into our lives? How do we incorporate wellness and mindfulness? How do you incorporate good sleep patterns and sleep habits? Because all of those things contribute to overall health, but also weight management. If her anxiety is significant enough that her physician feels like she needs additional care for that, we have built-in referral to behavioral health through an association with LifeStance. And so she would be referred there if needed. And then she follows back up with her telehealth physician about 3 to 4 months into her treatment. And that's really a point where we can sit back together and say, hey, these were the goals for this treatment. Are we meeting those goals? Did it work really well, but maybe that effect has worn off and we need to make an adjustment? It's just a great time to follow up with that. At that appointment, the telehealth physician is also going to review with Allison whether she's up to date on all her screenings. Because one of the really important things that we believe at Gennev is that screening is the key to long-term health. So we're going to ask about mammogram screening. We're going to ask about Pap screening and colon cancer screening because we need to be talking always about those health risks and how to prevent bad outcomes. And then after that visit, she can continue to work with her RDN team. Or if there's any reason why this person needs to be seen in person, whether it's for screening care or for a problem care, then we refer to one of our in-person OBGYN colleagues through our association with Unified Women's Healthcare. The model of this care is very collaborative. And we think that that's really the key to why our patients do so well with this type of care. So our patients, somewhere between, when we survey, anywhere between 87 and 93% of them report resolution or a great improvement in their symptoms. And it's because we work so collaboratively with the RDN team, but also with patients, primary care physicians, or in-person gynecologists. And that means that we have all the information we need, but also all the resources we need to help you achieve your best health, both from a symptom relief perspective and from a long-term care perspective. We employ the menopause certified physicians. We employ the registered dietitian nutritionist, but we also have a network of people who can serve other needs as well. So I'm going to have Devin come back on.
Yep. So I'll talk a little bit about next steps while you guys think about any questions that you have. So feel free to drop your questions in the chat. So next steps, you can visit gennev.com, set up a free account. With that account, that's how you can kind of book a visit. So it'll be based on your location, and you can upload your insurance information, and we do bill directly to insurance for Aetna, United Healthcare. And we have some out-of-network insurance as well. So definitely recommend you just go ahead and set up an account. Also on our website, there's a ton of information, educational resources. So as you think about educating yourself on what does this mean for me, or what if I have, excessively itchy skin, or is this normal? Our educational resources are a really great place for you to just learn more about this stage in your life and make sure that you get the care that you need at the right time that you need it. So I highly recommend checking that out as well. I haven't seen any questions come into the chat, but one of the questions that we often get is around hormone replacement therapy. So there was a study that came out a long time ago about the risk of hormone replacement therapy. So Dr. Rebecca Dunsmore-Sue, can you just address that and just kind of educate us about that study and kind of how our thinking has changed?
I'm happy to, Devin. As you know, I talk about this all the time. The poor team at Gennev gets to hear this day in and day out. And I didn't really go into it in the presentation because it almost always gets asked, but I'm glad you asked it. So I think what Devin was referring to is the Women's Health Initiative, which was released as a press release and then as a study back in sort of the 2002-2003 timeframe. And it scared a lot of physicians and women away from hormone replacement therapy. And I think that's a real shame because the study itself has a ton of good data, and a lot of that data is actually incredibly reassuring about the safety and benefit of hormone therapy. So what I always explain is that they sort of announced this huge breast cancer risk. Well, first of all, it wasn't a huge breast cancer risk. It was a tiny increase in incidence over the baseline. Second important point, that tiny increase in incidence went away when they controlled for inequalities between the people on real hormones and placebos. And the third important point was that incidence was already known. This wasn't actually really new data. And how much of that can be contributed to the progesterone arm of the hormone replacement therapy is debatable. The things they didn't hold a press release about are the fact that women who didn't have a uterus and didn't need progesterone actually had a lowering of their breast cancer risk with continued use of estrogen therapy. When I'm counseling women, I say, there may or may not be a slightly increased incidence of breast cancer when using hormone therapy over 5 years. That being said, 1 in 8 women gets breast cancer. So it's really hard to study this. It's such a common outcome that what is attributable to this risk factor versus that risk factor is almost impossible to sort out. The important thing about breast cancer is that we get our screening mammograms yearly from the age of 40. We catch it early and it is cured. The thing that nobody talks about, because we fear breast cancer totally reasonably, personal understanding of that. But we don't talk about the fact that breast cancer doesn't kill women. Cardiovascular disease kills women. Hip fractures kill women. And in fact, most breast cancer survivors are going to live long enough to die of a heart attack. So we need to be thinking about the global women's health picture when we're deciding whether hormones are or are not a good idea. And there's a lot of debate about whether hormones are good or bad for the cardiovascular system. That very much depends on when you start them in your menopause. And that's something we love to talk about at Gennev because we can go into your particular risk factors and whether or not this is a good choice for you. But in general, hormones are actually a quite safe and very effective therapy for a lot of the symptoms of menopause, and we use them a lot.
Great. Thank you.
I was going to say, I see someone asking how long do you stay on menopause? On average? The answer is that's different for every woman. So we use hormones for different reasons, right? So if we're using it for hot flashes, the average amount of time that a woman will have hot flashes is 7 years, but it can vary from 3 to 10 to 15. So if we're using it for a particular symptom, we might use it 5 to 7 years and then taper off and see if that symptom is still there. You don't just put it off, it does actually go away in the meantime while you're using the hormones. Some of my patients are using it for a multitude of symptoms, some of which are not likely to go away over time, so they might decide to continue it longer. A lot of my patients who are using it for more of the fatigue, sleep, brain functioning want to use it until they retire and then taper off because they're very functional and they feel good on it and it helps them to be as functional as they can be. So they might stop at 65 or 70. And then I have a small subset of patients for whom hormones just make them feel like themselves, or we're trying to protect them from bone loss because they already have osteopenia or osteoporosis, and they might continue it indefinitely. I have some 80 and 90-year-olds in my clinic who are still on a very low dose of hormone. All of these are safe choices. It's always a risk-benefit balance for that particular patient, and that's how we make that decision.
Great. We have a question here about how does the Gennev program work in conjunction with their existing OB? Is there handoff at some point?
Absolutely. So if you're working with an OBGYN for whom menopause or hormone therapy is not a comfort zone and you want to see us specifically for that, we are always more than happy to send a copy of our note back to your OBGYN so they know exactly what we're doing. We're in an electronic medical record and it can automatically fax that right to your provider. And if they have questions, they can always reach out to us and ask those. And oftentimes our EMR will connect to your provider's electronic medical record, and we can sometimes even see their notes. It sort of depends which one they're in.
Great. I have a question here about supplements.
My favorite topic.
Yeah, it's a great topic. So just as you guys browse our Gennev website, we do have a separate section on a product section that sells supplements. I will just kind of caveat that yes, Gennev sells supplements, but our clinical practice and our supplement practice are completely separate, and our doctors don't necessarily recommend specifically the Gennev supplements. From there, I'll let Dr. Rebecca take it from there.
Yes, so supplements are a really hot topic. They're also a really hot market. My take on supplements is that the best form of supplementation is to eat a balanced and varied diet. You're always going to get better amounts of those nutrients in your food than you will out of a pill. There are times when supplementation is needed because you can't access those nutrients through your food. So for example, I live in Seattle, Washington. I take a vitamin D supplement because there is no sunshine. And I do not drink dairy, so I don't even get the fortified milk. Fish oil, omega-3 fatty acids. Oftentimes, it's just really hard to get an adequate amount of that in your diet, and they're good for your brain, your heart, and your joints. But in general, you don't need a large handful of supplements if you're eating a balanced diet. Multivitamins, multi-supplements, all those things are generally not necessary. There are people for whom they are helpful, and that would be a good time to recommend those. And as Devin mentioned, our clinical team, both the doctors and the RDNs, if they recommend a supplement, we will tell you if Gennev sells it, but we will also give you other options and other places to buy it so you can make a decision yourself about where to buy that supplement. We are not a sales force. I get frustrated when I see people peddling supplements to cure menopause or to fix all your symptoms. No supplement anywhere ever has been studied and proven to do any of those things. Supplements are meant to enhance your nutritive status. They do not cure or fix menopause. And the other thing to keep in mind when thinking about supplements is no supplement is FDA regulated. So there's a huge carve out in our federal government that means that supplements are completely unregulated. So, for example, at Gennev, we have ours independently verified. That's always a good first step. But you never 100% know if you're getting exactly what's in that bottle, in that pill, because nobody is looking. So caution is warranted. And certainly if somebody is telling you one supplement can cure everything, then they're lying to you because no one thing does anything like that.
Thank you. I have a question here about heavy bleeding and what can be done to control it.
So this is a great question. I'm glad somebody brought it up because especially in that perimenopausal transition, we often see lots of heavy bleeding, both irregular and regular heavy bleeding. We sometimes refer to it as flooding in the gynecology circles. And what's happening is your estrogen is going very, very high to get those not so good eggs out. And when your estrogen goes very, very high at the beginning of the cycle, especially if the cycle is getting longer, so you're having more days where it's just estrogen, you grow a lot of lining in the uterus. And then when it comes time to have a period, all of that has to come out. So there are a couple concerns about that. Concern number one is that if you're having 2 or 3 month spacings between your periods and all that time seeing a lot of estrogen, you can actually turn that lining into a precancer or cancer. So that needs to be evaluated by a gynecologist and sampled either through a biopsy in the office or a small surgery with a camera. Number two, it's messy and annoying and can make you anemic. And so we need to treat it just on that basis alone. The best treatments are often hormonal. So I told you hormones are swinging all over the place. So we just make that stop. Most commonly with birth control pills. And people laugh at me all the time when they say, oh my God, I have to go back on birth control pills. I don't need contraception. I'm like, I'm not using it for contraception. I'm using it to turn off the ovary. So you get a nice even amount of hormone every single day. We run them continuously. So you only get a period that is very light every 3 to 6 months. And nobody seems to mind that. And we have great new birth control pills on the market now that are different in side effect profiles than some of the stuff you might have taken in your 20s or 30s. Another good option for controlling bleeding is a hormonal IUD. So we put a little T-shaped piece of plastic inside the uterus. It has progesterone in it and it just tells the lining to never grow. So no matter what your ovary is doing, the lining of the uterus just doesn't grow and the bleeding is very light or non-existent. There are also surgical options like burning off the lining of the uterus or even taking the uterus out. And those decisions are really, again, one-to-one decisions with a gynecologist. You talk to somebody, we make sure that we know everything is safe and healthy, and then we can give you all of the options and the risks and benefits of each for you.
Great. So you're talking a lot about different hormones. So progesterone, estrogen. Can you talk a little bit about testosterone when it comes to
you know
menopause?
me so well, Devin.
I do.
So I love to talk about testosterone and menopause because I want to reframe the thinking around testosterone. Testosterone is a female hormone. And I know that sounds controversial, but we've had testosterone our whole lives and it's been present in our system our whole lives. What's interesting though is that it's not a hormone related to ovulation. So when ovulation ceases, our testosterone production does not. A lot of women, especially in perimenopause, have a lot of issues with acne and hair loss and chin hairs. That's testosterone. That means you're seeing more testosterone than the estrogen and progesterone at this point. So the last thing you need to do is add more testosterone yet into that system. There's a lot of sales around testosterone being a great medication for sex drive, for energy, for muscle building. These are all true. The side effects of testosterone do those things. In fact, that's why testosterone is a controlled substance and is considered a doping agent if you use it to build muscle and then you play sports. That's what you are doing with the testosterone. Does it increase libido? If I give enough, we can increase libido for a short period of time until you get used to that level and then that effect wears off. So it's not a cure-all forever. What's the downside to giving testosterone? Well, you've already got it. First of all, we're not replacing something that is missing. Two, that's usually not the source of the problem with libido. The source of the problem with libido has to do a lot more with the lack of sleep, the changing body, changing relationships, stresses of being in the sandwich generation, all sorts of other things that are better worked on with strategies than a medication. And then the third risk is long-term effects. So if we give too much testosterone, you will get male pattern baldness and we can't take that back. You will get chin hairs, and we can't get those back out. Your voice can drop into a lower range, and that doesn't go back up if you stop. You can actually grow your clitoris into a small penis, which is always interesting. More importantly, on the inside, testosterone at higher levels changes your lipid profile. You'll have higher LDL, lower HDL, which is a riskier version of those cholesterols, and it can impact heart disease. So it's not without risk, and the benefits tend to be transient, and we can achieve those benefits in a long-lasting way with better understanding of the physiology and the therapies thereof.
Thank you.
Can I add one more thing, Devin? A lot of people go to these clinics for testosterone and they send a testosterone level and tell women their testosterone is 0. That's not true. Your testosterone is not 0. They have sent the test that reads male testosterone levels. That test is completely invalid at female levels. So if they don't send the right test, they're just not going to pick it up. So please, don't fall into that trap. It's a huge moneymaker right now out there between testosterone compounds and pellets and things like that. All of these are unsafe. Please come see someone who's expert in this and we can talk you through how we actually tackle all of these problems.
Thank you. That is my favorite topic because I learned so much from Dr. Dunsmore-Sue on this that I had no idea about. So I had to bring that question up. So a couple, just one follow-up question from the heavy bleeding previously. The question is, you mentioned burning the lining. Is this referred to as an ablation?
It is. That is an ablation. And ablations can be a useful surgery in certain patients. There are some downsides to ablation, the first of which is that it is not contraception. So if you are still ovulating and don't have another very reliable form of contraception, you can get pregnant still. And the scary thing about that is that now you have no lining for that pregnancy to implant in, so it tends to implant into the muscle and can be very, very dangerous. Second downside is if you're young enough, it's not going to last forever. So this is not a great procedure for someone who's 40. But it can be a great procedure for someone who's like 48 and has a couple years to menopause and hasn't done well with an IUD in the past, and then we can just stop their bleeding. And it can be very effective in those cases. The other thing we always think about and counsel about when we're doing an ablation is that once we've done an ablation, it can be very hard to sample the lining that's left behind. So if you're at higher risk for like a uterine cancer, it's not a good choice for you because we need to be able to access that lining and sample it.
Super helpful. How long is an IUD recommended? Is it recommended through menopause? I love this question. And about the cocktail that you guys often recommend. I'd love for you to talk about that.
Yes, we love IUDs. So the Mirena IUD is the one we typically use during this time period. It is currently approved in the United States for 8 years for contraception. It has been studied for up to 5 years in use in conjunction with estrogen for hormone replacement therapy. And I'll sort of explain why I make that distinction in a minute. So Mirena IUD is excellent contraception. You can use it through your late perimenopause to provide both contraception and bleeding control. It also has an FDA approval to manage heavy bleeding. So great, we can get it covered for that. You can transition into menopause on a Mirena IUD and just keep using that as your progesterone arm of your hormone replacement therapy because it is strong enough, at least out to 5 years, to counter the estrogen we might give you, which is great because then we don't have to do anything else. We don't have to think about the sort of systemic progesterone and have that complex conversation about breast cancer risk. Mirena IUD may or may not have that risk because it's at such low levels. Do we replace them in menopause? Yeah, sometimes we really like Mirena IUD and hormone replacement therapy as a cocktail. We struggle a little bit more sometimes with insurance coverage for that because it is not necessarily FDA approved for hormone replacement therapy. And then I just make a distinguish between 5 and 8 years because we've only studied it for hormone therapy out to 5 years. Now, if it's strong enough to continue to provide contraception for 3 more years, and in the studies where they looked at that, they didn't see any drop off in the levels that they were seeing during those last 3 years, it probably still works out to 8 for hormone therapy. We just haven't actually done that follow-up study. I'm very, very hopeful that that is going on somewhere. Yeah, and then the last thing we use the Mirena IUD for in the sort of perimenopause and menopause transition is actually precancers of the uterus. So Many of the earlier precancers of the uterus are really effectively treated with progesterones, and the IUD is probably the best one to do that. So we often use it in that setting as well.
Are you at higher risk for uterine cancer if you enter menopause younger?
No. So uterine cancer, and the uterine cancer I'm referring to, there are different uterine cancers, first of all, but the one I'm referring to when I say uterine cancer is endometrial cancer, or cancer of the lining of the uterus. And this is a cancer that comes up due to uneven exposure to estrogen and progesterone. So I like to think of estrogen as the fertilizer for the uterine lining, and progesterone is the lawnmower. It says, nope, no growth. If you have lots of fertilizer and no lawn mowing, then it grows and grows and grows. And once you get something that's growing and growing and growing, it can make mistakes in replication and as cells develop, and that's precancer and cancer. So if you have a lot of stimulation to growth and no stimulation to stop, that's when we start to see these endometrial cancers. So what are the risk factors for that? So the big risk factors for uterine cancer or endometrial cancer are high levels of estrogen. So any, estrogen we give you and don't counter with a progesterone. High levels of native estrogen. So women with more body fat make a little bit of estrone, and that converts into estradiol and can stimulate that. So heavier women have a higher risk. Diabetes and polycystic ovarian syndrome. These are women who have a lot of different risk factors for both being heavier, but also having those irregular cycles that mean you're getting 2 or 3 months of estrogen exposure before the progesterone shows up and empties out the uterus. So these are the main risk factors that we talk about. There are also endometrial cancers that are related to genetic syndromes, which also cause colon cancer. That's a pretty unique subset of those cancers. But if you go into menopause early, theoretically, you're seeing less estrogen to that uterus. And so you wouldn't necessarily be at a higher risk. It sort of depends on your unique risk factors.
What can be done with a loss of libido? I'm so glad that someone finally asked this question. It takes us a little while to warm up to get to the sex question. So thank you for asking that.
Yes, lots of things can be done for the loss of libido. So when we work with women on Gennev, what we do is we sort of explore I love the way that a couple of different physicians and sex therapists think about libido as driving a car. So if you've ever read Emily Nagoski's Come As You Are, or Dr. Mintz's A Tired Woman's Guide to Passionate Sex, and yes, we will put those titles in the chat. What they think about is, if you're driving a car, you have one foot and it's either on the brake or the accelerator, right? So what are the brakes that are preventing that libido? Those brakes are lack of sleep. If you are tired, the only thing you want to do when you go to bed is sleep. You don't want to get sexy. If you have pain with sex, that's a huge foot on the brake. If you're having relationship issues, if you're having stress, all of these things make your brain not want to go down that pathway. This is a reasonable adjustment. Remember, sex biologically is to make a baby. And if you're in a time of stress, why would you make a baby? That's a bad time to have a child. So this is biology. So what we have to do is move the foot off the brake and onto the accelerator. And that's just a matter of strategies. And those books that I mentioned have great strategies, especially Dr. Mintz's book, A Tired Woman's Guide to Passionate Sex. She does a great job of explaining this and sort of guiding you through some of the different things that we use. The other thing I always want to talk about when I talk about libido is what is normal, because we are told by society that everybody else is having sex every day or every other day. This is not true. When you survey women who are in this age range of perimenopause to menopause, the most common frequency, the top of that bell curve, is once every 1 to 3 months that they are having sex. That's normal. You are not abnormal. What is, however, important to think about is this functional for you? Is this enough sex that your relationship is maintained and that intimacy is maintained? Or do we need to work on that? Are you guys in a dissatisfied sort of tete-a-tete about how much sex should be happening in that relationship? So that we start with that conversation. The second conversation to have is the biological drive. So we think of libido as spontaneously feeling horny. That happens and I'm going to make a gross generalization because not all women are the same and not all men are the same. But in general, for women, that spontaneous desire tends to happen around ovulation because that is the time when you need to make a baby. Outside of that, most of our desire tends to be responsive or responding to arousal and intimacy. So if we feel like if we're not spontaneously feeling like jumping our partners, we don't want to have sex. That's not true. We still want to have sex. We just need to get there. And so working on strategies to get there is really, really critical. And the last thing I'll add on here is communication. If you are not communicating well with your partner about these challenges and how to face them, then you tend to grow apart, and then you're even less likely to want to have sex with that person. So a lot of it tends to be about talking and touching and cuddling the non-sexual ways so you feel close before you make that next step. And that is my brief libido 101.
That is great. Maybe Libido 101 might be our next
There you
webinar. So we have a couple questions here about how to manage these symptoms in the workplace. So first, before you answer, I will say this webinar alone is the start of how you can manage menopause in the workplace, just by educating across organizations about menopause, the symptoms we're experiencing, and making sure you don't feel alone and feel like you have someone to talk to, have someone to connect with in your organization about menopause. But Dr. Dunsmore-Sue, I'll turn it over to you in terms of what can be done about brain fog and things that really impact us at work and our ability to show up.
So in terms of actual performance things like brain fog or fatigue or things that can impact your ability to work no matter what the situation you're working in, that's where we really need to treat the underlying causes. So we need to treat your lack of sleep or insomnia. We need to be treating your hot flashes and night sweats that are keeping you up all night. And so that's where hormone therapy or other medications may be really critical in helping you perform at your peak. And estrogen therapy does tend to clear some of that brain fog as well, whether that's partly because you're getting better sleep and also partly because of the estrogen itself is somewhat debatable. That being said, for some women, hormones aren't an option or they don't want to use hormones. So that's where we start to talk about flexible working. So, if there are a couple of days a week where you're just not very functional, but you might be more functional if you can take breaks during the day, can you work from home? Can you space your day out? So, like if you had a terrible night's sleep the night before, you can take a nap midday. If you have to be in an office setting, make sure you have all the accoutrements. You have your fans, you have your water, you have all the things that can make you comfortable if hot flashes are coming and going, and dressing in layers and all of those things. See if you can turn your office temp down a little bit so it's just not so many hot flashes to deal with. Again, this is one of those things where menopause is different for every woman and her needs are different. And so it's a one-on-one conversation for how best do we manage this through this transition for you. And what accommodations can we make?
In that same vein, in terms of the care being really specific to the individual, a question came in. Any data on how HRT options or strategies impact different ethnic groups, specifically Black women?
I'm so glad somebody brought this up because the experience of menopause differs by ethnic group. This difference is not genetic, and I want to emphasize that. We are all one genetic species. The difference is probably related a lot to cultural expectations of menopause as well as chronic stress that some women in our society experience that other women do not. And we know that stress has a huge impact on some of the parameters of menopause, like hot flashes, like weight gain, like sleep deficit, like mood and anxiety. So if you're already at baseline living with a higher level of chronic stress, you're going to experience these things much more. We also have different health outcomes because of that level of chronic stress, right? Black women have higher rates of cardiovascular disease. They have an earlier death date. So we have to think about all of those things when we're thinking about hormone replacement therapy for them. In studies where some of this is controlled for, hormone therapy doesn't seem to have a huge difference in terms of risk or benefit among Black women or other ethnicities or races. However, again, this is really a one-to-one conversation because what we need to sort of think about, especially if you're already at higher risk for certain things, is what is your personal risk of heart disease? What is your family history? What are your symptoms and how are they impacting it? We know that women who have much worse hot flashes are at higher risk for heart attack and stroke, What we don't know is that the chronic stress of those hot flashes plus the chronic stress you're already experiencing that's putting you there, or is it the actual hot flashes and the vascular instability itself? And if we cure those, will we actually lower your risk? And that's a discussion we have to have one-to-one. But yes, we experience menopause differently for a variety of reasons, and therefore how it's addressed and what your risks are different.
Great. So we're coming to the end of time. We have a couple more questions that we will stay on and address, but I know some of you guys are going to have to drop. So I'm just going to launch a quick poll just to get a sense of, has your knowledge of menopause increased from this session? We want to make sure that we are providing you with the information that you need to be really empowered through your menopause journey, or to support a partner or a friend in their menopause journey. So I would love it if you would take this poll, and as you guys take that poll, I'll ask Dr. Dunsmore a couple more questions. One that we get a ton is, how do you manage weight gain and perimenopause? I dropped our Menopause 101 session from December in there. That was with Stacy Kazanchuk, who is our director of lifestyle care. She goes into detail about this, but I'll also have Dr. Dunsmore address this as well.
Weight gain is the hardest thing to manage through this transition. I like to bring us back to centering why is that weight gain happening? And it's a couple of different factors, but give your body a little bit of grace. It's trying to help. So we know that fat cells make estrone, which is a precursor to estradiol, which is the active form of estrogen. So putting on a layer of fat as you're heading into an estrogen deficient time is a good idea. Theoretically, that little bit of estrogen will help support your bones and your cardiovascular health. We just don't like it, and we don't feel good in it. And sometimes it's more than just a little layer of fat. What we know is that our metabolism shifts as we age and as we go through this transition. We lose muscle mass through this transition, and muscle mass is what burns calories, so that also impacts our metabolism. And lack of sleep brings your basal metabolic rate down. So all of these things are piling on to put weight on. Getting that weight back off is really hard. The things that used to work don't work anymore. And you may have changed nothing and gained 15 pounds, and that's a pretty common thing that we hear. So what we work on with you, especially with our RDN and lifestyle team, is how do we reframe the journey into eating the best possible, most healthy diet for you and your long-term goals. And if weight loss is part of that journey, that's great. But we really focus on balanced diet and reasonable activity and movement, and adding movement into your day anywhere you can, because those are the things that over time build it. Now, if weight loss is really a goal, then you actually have to be doing pretty significant lifting and strength training. Strength training is great for your bones, supports them, but it also builds that muscle mass, which will eventually burn calorie. And so really adding a lot more of that in is pretty critical. We at Gennev are no fan of any diet. Dieting is just a recipe for disaster. You can probably lose 10 or 15 pounds with a really restrictive diet, but you eventually have to eat food again, and it's all going to come right back. We also know from data and studies that it takes about 4 times as long on any diet to lose weight in menopause as it did before. So give yourself a little bit of grace.
Love that. So we'll finish on this last question. What type of HRT do you recommend, patch, gel, or tablets? And can it be started in perimenopause?
The answer is yes, I recommend all of those. It depends on your particular needs. We tend towards through the skin or transdermal estrogens, whether that's a patch or a gel, because it may be slightly lower risk for blood clotting. I never recommend a compound. Compounds are, one, unnecessarily expensive and unnecessary because we can adjust the dosing of hormone using FDA regulated medications very, very easily. 2, they're unreliable. Nobody is looking at that compound to actually verify that it's got what it says it does in it. You're not getting something more natural. I think that's the common thing that we hear. People are like, oh no, I use the natural hormones in this compound. Actually, it's the exact same synthetic hormone that's in my FDA regulated product because they're all made by the same lab. There is no plant-based estrogen. Estrogen doesn't come from a flower, it comes from a lab. Unless you're using the one made from horse's urine, which is arguably the most natural, but not the one we typically use anymore. In terms of progesterone, if you're using the natural form of progesterone or micronized progesterone, it must be in a pill. It does not get in through the skin. It's far too large a molecule, so any compound of that is not giving you adequate protection. And then there are a lot of other progesterone sort of molecules that we use sometimes, and those can be made into a patch or a pill or an IUD. Can you start in perimenopause? Yeah, towards the end of perimenopause, you can. If we started too early in perimenopause, then it just messes up your bleeding and it doesn't really solve the problems we're trying to solve. So the people who are earlier in perimenopause generally do better on a birth control type pill. There's a lovely new birth control out there. Come ask us about it. That's a different estrogen. So it's a lower potency estrogen. It's also currently being trialed as hormone therapy. So you're really sort of transitioning on something that functions as both. And we use that a lot.
Thank you. Well, thank you everyone for these amazing questions. I hope you got as much out of this session as I did, and that you do feel more empowered, feel less alone, but also recognize that this is your own journey and that you likely will need just kind of your own specialized care, and that is what Gennev does for you. So we invite you to set up an account, set up an appointment with one of our OBGYNs. We would love to be able to help you through your menopause journey. So you can visit gennev.com. If you're a Progeny patient, visit Progeny to receive these services through Gennev. We really, really appreciate your time. We will be sending through this presentation. So if you feel like you want to share this with a friend, with a colleague, please feel free to share it out. We want to make sure that everyone feels empowered during their journey in menopause. So thank you so much, and I hope you guys have a great rest of your day.
Bye, everybody. It was great talking to you. Thank you for the great questions.
Great, thanks. Bye.